Hello, everybody. My name is Yayoh Kamara. I'll be presenting on session 3, which covers phases 1, 2, and portions of phase 3. And Angelica, can you please switch the slides? Okay, so I'll be presenting on phase 1, 2, and portions of phase 3 of the patient care journey. So in this session, we'll be discussing the workflow, which consists of the people, the process, and technology needed to empanel our patients. We'll also take a look at the minimum data sets needed for each transitions of care. We'll discuss the empanelment process, risk stratification steps, and alternative office visit options such as virtual visits. Lastly, we'll be reviewing documents such as longitudinal care management plans, behavioral health screening plans, and self-management support. Next slide, please. So phase 1 is any encounter that occurs before the patient has the office visit or virtual visit. So this will include contact with the patient to confirm their appointment scheduling and reminder calls, prior visit data review, which includes having a review of any data-driven care improvement plans and its risk stratification report, and pre-visit huddle of the care team. Next slide, please. So here we have our test patient, Ms. Anexa. She is a 71-year-old Medicare beneficiary. She has a clinical profile, she has a social profile, a personality profile, a utilization profile, and a cost utilization profile. If you look at her clinical profile, she's a type 2 diabetic. She has hypertension and CHF, and she's dependent on opioids. Her utilization profile shows that within the last 6 months, she's had 5 emergency department visits and 2 hospitalizations, with the last one being for treatment for uncontrolled CHF. So the patient's journey handout is in your handout packet, and you should have it downloaded. So I'm going to ask that you follow along on this slide. Some of the things I'll be discussing with you today are things you already know because that's what you do every day. But as Dr. Okeke stated earlier, our goal is to discuss your day-to-day work in context of the MDPCP program and point out new information, the program requirements, and ways you can advance in your primary care journey. The appropriate requirements will be highlighted in the red text located right here. So do look out for those as we move along. Now, starting with prior encounters you have with the patients before the office or virtual visit. In this phase, anyone on the care team can interact with the patient for various reasons, either to remind them of their appointments or to follow up on any needs that they may have. The encounters occur in multiple ways, either by phone calls or through secure messaging using technology such as EMRs. And now with the COVID-19 screening, you can use that to screen your high-risk patients. And to learn more about COVID-19 front desk triage workflow, practice process maps, and phone scripts, please access the links located right here on the slides. Lastly, we also want to keep in mind the patient's experience. Ms. Anexa is happy to have access to members on her care team. Next slide, please. So reviewing the patient care empanelment is always good for us to know our why. Why do we empanel patients to a PCP or a care team? Empanelment promotes continuity of care. It helps build a trusting relationship between the patient and or provider. It promotes better health outcomes. It improves provider satisfaction and patient satisfaction, and it facilitates panel-level population management. And the empanelment process should include the following steps. The first thing you want to do is you want to identify your active patients, and to do so, you can use a look-back period of about 24 months. You want to empanel your patients to the PCP and or care team, and to do so, you first want to identify the care team. You want to define the provider-patient ratio and assign the high-risk patients to the more experienced providers and the lead care managers. And remember that patient preference should also be considered. After you've defined your empanelment criteria, you want to empanel your patients and identify in your EMR. You should also do a panel review periodically, like every quarter, to keep your patient panel active. The third step in the empanelment process is to measure and optimize continuity, and this is done by determining the preferred method of measuring continuity. So the next is appointment scheduling. Now, as you know, this is done mostly within your EMR, and different EMRs are configured differently. The most important thing is to keep in mind that you're scheduling your patient's appointments with their empaneled physician and or care team member. Again, we also must keep in mind the patient's experience. And at this stage, Ms. Anexa is happy that she's getting reminders to her appointments, which in turn can reduce the number of no-show rates in your practice. Prior to the patient's visit, the care team can conduct patient chart and patient panel report review. Some reports are reviewed on a daily, weekly, monthly, or quarterly basis. An example of panel reviews are disease-specific or ECQM-specific EMR dashboard. Those are reviewed on a monthly or weekly basis. Care team panels scheduled for office visits in the coming week. Those are reviewed on a weekly or daily basis. And the CRISP report or pre-AH tool reviewed monthly. And the ENS notification reports are reviewed daily. So next we'll discuss the risk stratification. Why do we risk stratify? We risk stratify because it provides an actual view. It targets resources for our patients to demonstrate their greatest needs. It supports our efforts to address care management needs for our high or rising risk patients, and it addresses preventative care needs for our low risk patients. So risk stratification involves several steps. The first step is shown on this slide, which is providing an algorithm-based stratification, and it's based on diagnosis claims and other electronic data that helps populate a population-level stratification for each patient. So there are a variety of algorithm-based methods available. In MDPCP, we promote the CRISP data and the pre-AH tool to be used for your risk stratification, and recently, the pre-AH tool has been enhanced with the addition of the COVID-19 Vulnerability Index, which you can see right here. That's the link to it right there. And to learn more about the CRISP pre-AH tool, please visit the links to the recorded webinars. And remember, you can also reach out to your CTO and practice coaches. And like I said, the links to the recorded webinars can be found in the green box below. Next slide, please. So now we have a poll. We like to ask how many of you have started using the CRISP pre-AH tool. If you don't mind just answering, selecting one of those if you've not started, if you've started but used rarely, or if you've started but used regularly.
We'll close the poll in about 10 seconds.
Okay, so that's awesome. 55% have started and they're using it regularly. So for those of you who started using the pre-AH tool, great work, and we hope that you find it helpful. If you have any feedback on using the tool, please share your feedback with your practice coach. And for those of you who are yet to start using the pre-AH tool, please review the recorded webinars in the links on the previous slide, and also reach out to your CTO or practice coach to guide you on how to use the tool, because it's very helpful. So here we have step 2 of risk stratification. We already just talked about step 1, which is using an algorithm. The second step in risk stratification is to apply your clinical intuition. We want to apply our clinical intuition because, as you know, sometimes there can be errors in data, or sometimes the algorithm doesn't see the full clinical picture. So you being the clinician, you know your patient, you're evaluating your patient's risk level, taking into consideration what you know about your patient, which includes their social needs, their health literacy, their support systems, and their behavioral and medical needs. And based on that assessment, you can assign a higher or lower risk score. And not until you've applied your clinical intuition can you say that you've really completed the risk stratification process. And this can be revisited periodically. So next, the care team conducts the pre-visit huddle to specifically discuss patients on their panel. So as you know, the care team comes together to discuss the patient's care. Everyone on the care team discusses the patient from their perspective. And again, as we said, this also should be data-driven and chart review based on encounters that each of the care team members have had with the patient before the visit. We have to keep in mind that even though Ms. Anexa isn't with the team at this point, what we're doing does elicit a positive response down the line. So when she does come in and see the physician or provider, and they're able to articulate everything going on with her and all her care needs, it will elicit a positive experience because she'll feel like, they know her, they're concerned about her care, so this is a positive experience for the patient. So let's talk about care team huddles. Care team huddles are evidence-based tools. They're used by the primary care team. They should occur daily, and they should have an agenda. If they're done well, they should be no more than 10 minutes. And this is the time you should discuss or call out patient care needs. So one approach to identify the patients to huddle on is to use the list of patients scheduled for visits on that particular day and to review them as a care team. Another approach would be to use a disease-specific registry such as diabetes to review the care needs of those patients as a team. Okay, so now we have a team huddle video just to show you an example of how a team huddle should work so you can see it in perspective.
Are you ladies ready to huddle?
Yeah.
Okay.
Some add-in spots for the day. We could do a 9:30, 11:30, a 2:15, and a 3:30.
That looks great.
And then I will have our scheduler call the 2 o'clock since Ted chronically misses his appointments.
Okay, thank you.
Okay, our first patient of the day is Sue. She's coming in for an ER follow-up. She was seen within a different system, so we will have to get those records pulled for her.
Okay.
And that A1C that we added onto Mary's labs came back, and her result came back to a 7, so we could do some warm handoff to the RN for some diabetes education.
Okay, great. Give them a heads up about that.
Okay, Jane, she's coming in for some lower back pain. Then we can see if the physical therapist can see her if she's eligible.
Okay.
And then we have Ed coming in. He doesn't have any insurance, so we could possibly do a referral to case management.
Okay, and if she's available, we'll make that a warm handoff.
Okay.
Okay, our last one of the day, Bob, he's coming in for his Medicare visit. He is a candidate for CCM, so we can see if he wants to set that up today. He is our last patient of the day, so we can probably start to see our patients now.
All right, great. And you're going to get that huddle handoff sheet ready for everyone?
Yep, I'll get one to the RN and the scheduler.
All right, thank you.
Morning, ladies.
Morning.
All right, here's a huddle handoff form for each of you. On here, we have some spots where you can do some add-ins. And then Sharon, if you could call our 2 o'clock Ted, just because he tends to miss his appointments. And then Teresa, we have our 8 o'clock patient. They're going to be a new diabetic, so if you could do some education at the end of the visit. All right, sounds
Great,
good.
thank you.
Thanks.
Have a good day.
Paige, do you want to go ahead and start visit prep, and I'll go in and do in basket?
Yeah.
Dr. Rachel, I was viewing results, and Mary's glucose came back elevated at 120. I'm going to go ahead and add an A1C.
Oh, perfect. Thank you.
Okay. Looking at our chart prep for the day, Joe is coming in. The only thing it looks like he's due for is his colonoscopy, so we will get that ordered for him today.
Great, and go ahead and schedule it right away too, please.
Bobby Joe's PAP came back normal, so I'll go ahead and message her through the online portal.
Thank you. And Paige, I noticed that Lisa's TSH came back a little bit high. Would you mind sending her a message through the portal that I'd like to increase her levothyroxine to 100 micrograms once a day and repeat that TSH in about 4 to 6 weeks?
All right. We will get that levothyroxine sent over to her pharmacy. I'll get the order put in for that TSH, and we'll message that all to her on the portal.
Thank you.
And on Kathy, we received a prior authorization paperwork for her Vibrid. I called the pharmacy already, and they will do sertraline. Do you want to go ahead and order the sertraline?
She actually failed sertraline, so if you don't mind doing the prior authorization, I'd appreciate that.
Okay, I will do that.
Thank you.
Excuse me, Dr. Rachel, you have a moment?
Yeah.
I have a patient of yours on the phone, Sarah. She's been sick with cough, chest congestion, about 10 days. I was tried over-the-counter medication, not getting better. Now it seems to be settling more in where she's having a hard time catching a deep breath. I'm wondering if you can see her at all today?
I think all of my double booking spots are filled up. Maybe we can check with Eric.
Okay.
Eric, would you have room to fit a patient in your schedule today?
Yeah, I should have room later this afternoon. Is it a patient I've met before?
Yeah, her name is Sarah. You've seen her in the past.
Okay, yeah, I think I know who that is.
Okay.
What time would work for you?
About 2. I should
Okay.
have an opening at 2. If you can put that in my schedule, that'd be
Perfect.
great.
I will. Thank you.
Okay.
You're
Thanks.
welcome. Also, Dr. Rachel, I have a patient later this afternoon who kind of non-compliant diabetic, having trouble managing her sugars. Would you mind helping me later this afternoon with her?
Sure. Let me know when you want me to pop in the room and we can take a look at her together.
Perfect.
I also have a patient that I'd like to bring you in on later. It's a well-controlled diabetic, and I'd just like to introduce you to the patient and maybe have you do their next follow-up so that if I'm ever out of town, they're comfortable with you taking
Absolutely.
care of them.
Absolutely.
Okay.
Thank you.
Thanks.
So hopefully the video was able to illustrate what a good daily huddle should look like. It was short, they discussed their patient's need, and they had an agenda. So in the next 2 slides, we're going to look at team huddle templates. This is a template of a team huddle checklist. You can also find this in the handouts that you downloaded. As you can see on the checklist, you want to make sure you start the team huddle in high spirits. Ask everyone how they're doing, especially during the COVID-19 pandemic. And then you want to look through the schedule and appointments and discuss the patient needs for the clinic day and care needs outside the scheduled visits. Also, don't forget to celebrate your team. So make sure you give a shout out and give kudos to those doing a great job and end on a positive note. And here's a template that you can use to summarize patient care gaps that can be discussed. You can discuss your patients based on needs such as screening and immunization needs, clinic lab work needed, and their last follow-up or last need. In phase 2, we're focused on the actual office or virtual visit. And in this phase, we'll be reviewing activities during the check-in, the rooming, the consultation, the pre-consultation, post-consultation, and the checkout. And during the COVID-19, very few patients are seen at the practice site. However, care team members should maintain the CDC guidelines for social distancing in the workplace, such as 6 feet distance between care team members where possible, and wearing PPE. So at this time, requests for PPE should be routed through your local health department since PPEs are in scarce supply. And we have the links here where you can see where we have the PPE supplier list and the request forms and local contacts. This next slide shows how to check in the patient and checking in our test patient, Ms. Anexa. Even though in a virtual visit, this is done over the phone, you still do what you normally do, which includes verifying the patient's insurance, updating their contact information, accepting any copays, and updating any previous questionnaires. And again, with virtual visits, you may want to call the patient a few minutes before the provider's visit to check for any connection issues. And again, this also helps with the patient's journey and their experience because they'll appreciate having the call prior to their visit. During the check-in, some additional info to share during COVID-19 is to emphasize that you're here to support your patient's medical needs. You want to encourage your patients to have their caregivers maintain distance from others and frequently wash their hands. You want to encourage patients to maintain a 2-week supply of food and medicine. You want to encourage them to move around while at home or exercise. You want to encourage them to rest often and stay connected virtually with friends and family. And for more resources, these are links to flyers for your waiting room. And the links can be found in this green box at the bottom. The links are from the CDC and patient flyers from the MDPCP program that you can send to your patients. With a regular office visit, you would normally room your patient, then notify the PCP. With virtual visits, depending on the workflow in your practice, the MA can still room the patient virtually and then hand off to the PCP. And this slide just shows the storyboard of Miss Anexa's summary. Here you can see the required activities for rooming, such as allergies. Well, the MA would have to fill out the allergies, the reason for the visit, the med review, and so on and so forth. Additional activities that's done before the PCP visit for a regular office visit would include checking the patient's vitals. And in the case of a virtual visit, we would want to record the self-reported results, especially with our patients who are diabetic or hypertensive. You can also do a behavioral health screen and do an annual wellness visit during this time. So activities that occur before the consultation with the PCP are listed here. And as you see, most of them are also MDPCP requirements. So to learn more on behavioral health screening, please click on this link at the bottom. It'll take you to the MDPCP website. These behavioral health integration mini-series are comprehensive, and they tell you more about how you can integrate behavioral health in your practice. The second link takes you to the webinar on SBIRT that shows how to screen your patients on substance abuse. And the annual wellness visit is basically, obviously, a yearly appointment with the PCP to review the patient's wellness and develop a personalized preventative plan. And the MDPCP beneficiary attribution to a practice is generally determined by having this annual wellness visit and welcome to Medicare visit, and by the plurality of eligible primary care visits within the 24-month look-back period. So the two CPT codes needed to bill for that is G0438 for the initial visit and the G0439 for subsequent visit. So different practices use different platforms, and they include their EMR, their virtual visit capability, such as Teams, Doxy.me, etc. There are differences. For example, for Teams, you can schedule your EMR, you can do video calls, but for Doxy.me doesn't have that capability, even though it's more user-friendly. So during the consultation, the PCP focuses on the patient's health concern and medication management, applies clinical judgment to adjust the patient's risk level, orders additional tests, and makes necessary referrals. And here we have a short, warm handoff video to play to show you how the MA hands off to the PCP in a regular office visit. So as you watch it, think about how this can be in a similar virtual setting.
Engaging patients and their families can improve patient safety in the primary care environment. One way to do this is through the use of a warm handoff. A warm handoff is a handoff conducted in person between two members of the healthcare team in front of the patient and family or caregiver. A warm handoff is similar in concept to nurse bedside shift report and engages the patient as a member of the team so that he or she can speak up, ask questions, and clarify information.
Hey, John, how you doing?
I'm doing all right, Doc.
Mr. Winston is now a proud grandpa.
Oh, that's right. How's your son's family doing? I bet it's exciting having a new grandbaby in the family.
Oh, yeah, it is. They're doing great. Thanks for asking. By the way, this is my daughter, Sue. She helps me with my medical stuff.
Welcome, Sue. Nice to meet you. So, let's have your report, Amelia.
Well, Mr. Winston said he experienced an episode of rapid heartbeat while he was working at home 2 nights ago. When his heartbeat wouldn't slow down, he went to the emergency room and they kept him overnight for additional testing and observation. They diagnosed him with atrial fibrillation and prescribed Xarelto, 10 milligrams to prevent stroke. There's no history of AFib in his charts. His pulse is 52 and his blood pressure today is 135/80, and he's lost 5 pounds since he was last here 2 months ago. He's still taking his Lipitor for his cholesterol.
Rapid heartbeat. And this never happened to you before?
Well, it has. I just didn't tell anyone about it.
Dad, why didn't you tell me?
Well, it was such a small thing, I didn't want to worry you about it. And it stopped on its own, so I thought everything was okay.
I want to hear what happened both times. Let's start with what happened 2 nights ago.
Okay, so a couple nights ago, I got home from work.
Warm handoffs improve communication, encourage engagement and questions from patients and caregivers, allow patients to clarify or correct information, build relationships, provide a safety check. As you'll see next, even a passing comment can lead to the identification of safety risks.
Amelia, do you have any information from the hospital?
I got the hospital to fax over the discharge summary, and Mr. Winston brought his discharge instructions in with him.
That's great.
Mr. Winston was seen by Dr. Ortiz, the attending cardiologist, at 10:15 on Tuesday nights. After Mr. Winston was diagnosed with atrial fibrillation, he was prescribed Xarelto 10 milligrams once a day, which Mr. Winston says he's filled today and has started taking.
That makes sense, but I was told 3 times a day, not once a day.
May I see the discharge summary, please? The blood thinner Dr. Ortiz prescribes is only taken once a day. The instructions from the cardiologist says you need blood work in 3 months. Maybe that's where things got mixed up. You take 1 pill once a day with your evening meal, and in 3 months you come back in for blood work, and we'll see how things are going.
That makes sense, but this thing is kind of confusing.
Just to be safe, I want to make sure we're all on the same page. Can you tell me how you're supposed to take these pills?
I take one of these pills, Xarelto, once a day at dinner time.
Yes.
Can he take it in the morning at breakfast?
No, this should be taken in the evening, and it's important to take it with food. Okay, now, let's take a look at you. Thank you, Amelia.
It's so nice seeing you both.
The warm handoff is a tool that primary care practices can use to better engage patients and families and to improve communication. This can lead to safer care, better patient understanding, and greater patient satisfaction.
Okay, so as a recap, we went over what happens during a consultation, and basically it involves the warm handoff, a review of the pre-consult assessment. We addressed the patient's health concerns. We did an examination and virtual observation, reviewed risk scores, discussed additional tests and care gaps, and discussed medication management. As you know, after seeing the PCP, the front desk staff and the MA assist the patients with the following. They help with follow-up appointment scheduling, with patient education, referrals, prescriptions, and lab work. So now we'll get a little bit into phase 3. We'll review 2 key activities that usually occurs after the office or virtual visit. These are longitudinal care management and also the post-visit data reviews. The remainder steps in phase 3 will be reviewed in the next session. So there are a number of referrals that can be made for the patient based on their healthcare needs. This can include referrals for provider specialists, pharmacists, social workers, or nutritionists. One key requirement for MDPCP is to ensure that you would identify your high volume or high cost patients and establish a care collaborative with them. We also discussed more on care collaboratives in the next session. So how do we implement our post-consultation findings? A longitudinal care plan are holistic, dynamic, and patient-centered plans. They focus on disease prevention, treatment, interventions, and goals. We want to know our why. We want to identify our high-risk patients. We want to provide outreach and enrollment. We want to do a care management assessment, establish a care plan, implement the care plan that we've established, and then we want to evaluate and analyze our care plan. So this is an example of a care management assessment and care plan. It is a comprehensive care management. It includes the patient's information, their medical, their physical, their mental health, their housing and environment information, their social, transportation, and vocational, and all of this can be done virtually. So one of the key requirements for managing your longitudinal patients is to make sure you have a care plan in place after you've done an assessment. The AAFP tool, which you see here, gives you an evidence-based guideline on how to develop a care plan. So for an example, in a high-risk patient with diabetes who is at a level 5, the care plan would include things such as patient education, self-management, home self-monitoring, fall risk management, and referral to CHW. to link to community resources. So you also want to make sure you document care plans and follow up care in the EMR. Self-management support is the care and encouragement provided to people with chronic conditions to help them understand their central role in managing their illness, making informed decisions about care, and engage in healthy behaviors. And one tool we use to measure the patient's activation and readiness to change is the PAM survey. So for Ms. Anexa, her PAM score is at a level 3. So she's a good candidate for self-management for her diabetes and hypertension. So we want to provide support with education about her chronic illness. We want to help her or give her a referral for health coaching and referrals to other support groups. You also want to help her with securing DME such as assistive devices and technology, and want to remind her on online tools and apps that can help her with lifestyle changes. So here is Ms. Anexa's individualized care plan. The problem is medication management and compliance, and we have 2 goals, one being a care management goal and the other a self-management goal. So for the care management, we have Ms. Anexa will receive medication education and counseling at her next office visit. The intervention we'll do there is the practice pharmacist will meet with Ms. Anexa at the next office visit. The outcome, Ms. Anexa will need ongoing medication follow-up to ensure she's compliant with her meds. And this is going to be an ongoing action. For goal 2, Ms. Anexa will take her meds as prescribed every day for a week. Our intervention will be that she's going to receive an electronic medication reminder pill box that's going to send daily reminders to the care team, or a daily reminder report rather, to the care team. And the outcome is Ms. Anexa had taken all her medications as prescribed for the week, and the goal was completed as the action. So here we have another poll. How many of you have established longitudinal care management in your practice? You can choose either not started or started.
All right, guys, about 10 more seconds before we close the poll.
Okay, so about 68% have started. So for those of you who've established longitudinal care management in your practice, you're well on your way to improve care delivery, especially for your high-risk patients and also their health outcomes. And for those of you who have not yet established them in your practice, you should now have a good guidance on how to do so based on what we've discussed. Again, also you can feel free to reach out to your CTO or practice coach to support you. So just a quick session recap. We used our test patient, Ms. Anexa, to have a practical conversation about activities that usually occur before, during, and after the patient's PCP visit. And we reviewed key requirements on using data to continuously improve care delivery. We discussed empanelment and continuity. We discussed risk stratification, team huddles, medication reconciliation and medication management, ECQMs, using data to continuously improve care delivery, annual wellness visits, behavioral health screenings, and longitudinal care management and care plans. Thank you for listening. I hope you found this session helpful, and I'll be here at the end of the session to answer any questions.
Thank you, Yayoh. So this brings us to our last break for this training session. So it's about 2:49, so we'll break for the 5 minutes, and then we'll reconvene with the last training session. Thank you.